Good morning, ladies and gentlemen. This is Dr. Rajesh Pande again, and today I'll be discussing about the management of sepsis in 2023. It was very exciting time when I was a senior resident because the newer definitions of sepsis were being unfolded and our whole understanding about the sepsis was changing. So what I will essentially do in this lecture is look at the pathophysiology of sepsis and also discuss about the definitions of sepsis, how they evolved over time, and then focus on the current surviving sepsis guidelines, and also giving you a glimpse of where we are heading in terms of precision medicine in the management of sepsis. So now this is, what happens initially when you have an initial insult due to bacteria, virus, or any other inflammatory, both it's common, inflammation as well as infection. So you have local pro-inflammatory response as well as anti-inflammatory response. And there is, as a result, release of pro as well as anti-inflammatory cytokines or inflammatory mediators. And there is it may lead to a systemic inflammatory response syndrome, which we know very well as SIRS, or it could be a compensatory anti-inflammatory response, which was labeled as CARS, or it could be a mixed antagonistic response syndrome, which was labeled as MARS. And finally, in early 1997, it was hypothesized that this leads to chaos. That is cardiovascular compromise, that is shock, homeostasis problem, that is shock, apoptosis, that is cell death, organ dysfunction, and suppression of immune system, that is CARS. So this was the understanding that we had early on in the 90s. And if you look at the involvement of our immune system, now innate immune system detects the invasion through pathogen recognition receptors, which is a subfamily of toll-like receptors. So innate cells, as we know, are expressed on the epithelial barriers, and immune cells like dendritic cells and macrophages. So these toll-like receptors on these cells will identify the pathogen-associated molecular patterns seen with infective organisms, which could be lipopolysaccharide for gram-negative bacteria and peptidoglycan, lipoteichoic acid, etc. for gram-positive, and then could also be flagellin, bacterial DNA, etc. So after they identify a pathogen-associated molecular pattern, they cause a downstream signaling cascade, and there is activation of nuclear factor kappa B, which finally leads to production of cytokines, chemokines, and nitric oxide. So this is our innate immunity. Innate is something that we inherit and it doesn't change. So this is what we get from our forefathers. So next important thing is, now both the adaptive immunity also comes into play. And as you know, the adaptive immunity is based on our exposure to the environment during our life cycle. So innate immunity, just to recapitulate, there is TLR identifies the pathogen PAMPs, and then there is a response. TLR2 will identify the gram-positive peptidoglycans. TLR4 will identify lipopolysaccharide. And then there is release of inflammatory markers, pro-inflammatory IL-1 beta, TNF-alpha, and anti-inflammatory like IL-10. So these cytokines or inflammatory mediators will damage the endothelium, and they will also activate the neutrophil. And that will release the nitric oxide. Simultaneously, the adaptive immunity also comes into the picture, and the beta cells, which are the immunoglobulins, will capture, they will bind to the microorganism, they will bring it to the neutrophils, which will eventually kill them. And also through the T cell. Now, T cells are helper T cells are also called CD4 cells. So we have the T helper cells 1 and T helper cell 2. So what they do is type 1 or Th helper cell 1 will secrete the inflammatory markers like TNF-alpha, IL-1 beta, whereas the type 2 Th2 cells will secrete the anti-inflammatory IL-4 and IL-10. And there is activation of the epithelium. Again, there is cytokine release. And these cytokines will also activate the endothelium, the capillary endothelium that is activated, leading to platelet activation. And finally, there is WBC or leukocyte activation, complement activation, coagulation cascade is also activated. And this culminates in a sepsis response, which is manifested as clinically as fever, capillary leak, vasodilation, and coagulation. Now, broadly speaking, in simple terms, infection will lead to inflammatory mediators. They will cause endothelial dysfunction as well as vasodilation. And there is shock, microvascular plugging, vasoconstriction, edema, and there is maldistribution of microvascular blood flow, and there is ischemia leading to cell death and organ dysfunction. So clinically, what we see in sepsis is endothelial dysfunction, coagulopathy, cellular dysfunction, cardiovascular dysfunction. Because of endothelial dysfunction, damage to the glycocalyx, there is capillary leakage, there is disseminated intravascular coagulation because of coagulopathy, and cellular dysfunction leads to a catabolic state. Cardiovascular dysfunction may lead to left ventricular dilation and hypotension. There is reduced tissue perfusion, reduced cellular energy consumption, finally leading to multi-organ failure. So this was very nicely illustrated in this New England Journal of Medicine cartoon. So you can see that this diagram is depicting the host pathogen interaction. So this is the TLR receptors that you can see. So they have identified the PAMPs. Now the pathogen will also have a lot of things to affect the response. It may overwhelm the response if the load is too high, or if it is very virulent, or it has PAMPs which cannot be identified. On the other hand, the host factors will also depend how much modest response the body can produce based on the environmental factors, the acquired immunity, the genetics, innate immunity, age. Elderly generally will have more issues. Comorbid conditions will have more issues, and if any immunosuppression or steroid medications are going on. So because that may mask the response. And the red is here excess inflammation causing collateral damage, and here there is immunosuppression, enhanced susceptibility to secondary infection. So you can see the same thing here, and you can see that there is a hypothalamic pituitary adrenal axis also comes into play. And finally, you have either of the two or a mixture of the two, anti and pro-inflammatory response. It's difficult to understand what is the predominant cytokine playing in sepsis, or what is the phase. That is why most of the therapies targeting these individual cytokines or individual phases have met with failure. Now, this cartoon tells us about what is happening at the cellular level and the tissue level. So you have this is the capillary endothelium, which represents the microcirculation. So you have increased coagulation leading to thrombus formation, microvascular plugging. Anticoagulation is decreased, which is the protective phenomena, because the protein C or an activated protein C are decreased. You remember long back in 2000, we had the PROVIS trial where in sepsis patients, activated protein C was infused from outside. The drug was called dotricogen alpha or Zygris, with a view to control the intravascular plugging and reduction in mortality in sepsis. So the PROVIS trial showed about 7-8% improvement in mortality, reduction in mortality. However, subsequent trials that were done did not show as much benefit, and finally the European PROVIS shock trial that was done did not show the benefit because the risks were high, risk of bleeding were high. So the drug was finally withdrawn after almost a decade. So in the capillary, there is a damage to the capillary. As you can see, there is loss of glycocalyx and there is capillary leak. And because of all these things that are happening, there is shock, there is tissue hyperperfusion, there is mitochondrial dysfunction, there is decreased tissue oxygenation, there is edema of the tissues, and finally, there is organ failure. So that is the crux of the matter here. Most common infection that can cause sepsis or septic shock are lung infections, followed by abdominal, then the other infections, as you can see here. Lot of things where we have fever, tachycardia, leukocytosis or leukopenia, tachypnea, or altered mental status, they all may be confused as sepsis and have been labeled as sepsis mimics. So we can see the sepsis itself and neuroleptic malignant syndrome, serotonin syndrome, malignant hypothermia, but they all are different. And as a student, you have to know that these are the mimics which may also present as sepsis. And inflammatory conditions like pancreatitis, trauma, burns also may have a presentation which is similar to sepsis. So now the next part is about the definitions of sepsis. Now, please understand, before 1992, the researchers were using their own definitions of sepsis, and there was significant heterogeneity in terms of the criteria used. You can understand the problem in doing a systemic review or a meta-analysis with such diverse definitions of sepsis. So 1992, Roger Bone published the first accepted consensus definitions of sepsis. The idea was that the researchers across the globe would be using the same definition to identify septic patients, so that there is uniformity in the research and it could be better analyzed. And subsequently, the definitions underwent modifications, like the ARDS definition, so they are ever evolving. Sepsis 1 was, sepsis was defined as systemic inflammatory response syndrome. So they coined the term SIRS, which was due to suspected or confirmed infection, and there have to be 2 or more criteria, like temperature below 36 or above 38 degrees centigrade, heart rate greater than 90 per minute, respiratory rate about 20 per minute, or arterial partial pressure of CO2 less than 32 millimeter, WBC less than 4,000 or more than 12,000, or more than 10% band cells or immature cells. As you can see, these criteria are non-specific. A lot of patients admitted in the ward will also have these. So the SIRS criteria were controversial, even in the beginning. Then they said that if there is progression of patients who have at least 2 of the above SIRS criteria to organ dysfunction, say develops acute kidney injury or develops respiratory failure, PF ratio comes down, or there is hyperlactatemia, or patient is in shock, then we will call it a severe sepsis. Septic shock was when there was hypotension and organ dysfunction that persisted despite adequate fluid resuscitation, requiring vasopressors, and patients already had 2 or more of the SIRS criteria listed. So this was the concept at that time. So you can see a lot of things would call SIRS. This is the inflammatory pathology, and this is the infective pathology. And where the pathology was either proven or suspected sepsis, it was labeled as sepsis, but it was fulfilling, the 2 or more of the SIRS criteria, as well as presence or suspicion of sepsis. And when there was organ dysfunction was also present, it was called severe sepsis. And when there was persistent hypotension, despite fluid resuscitation requiring vasopressors, it was called septic shock. However, people were unhappy with the SIRS criteria. There was a lot of criticism. So in the early 2010 or 11, the second definitions of sepsis were unveiled, where they tried to group them into various categories. And for example, they said general variables. So sepsis was documented or suspected infection plus one of the following. Now, what were these things? They were general variables included fever, hypothermia, elevated heart rate, tachypnea, altered mental status was included here, and substantial edema or positive fluid balance, more than 20 ml per kg of body weight over a 24-hour period was also included, as hyperglycemia was also included, plasma glucose more than 120 milligram per dl in absence of diabetes. So these things were collectively called general variables. And then they had inflammatory variables, leukocytosis, leukopenia, more than 10% band cells, and elevated plasma C-reactive protein, more than 2 standard deviation above the upper limit of normal, as well as elevated plasma procalcitonin, more than 2 standard deviation above the upper limit of normal. So as a student, you should know that initially it was suggested that the plasma calcitonin, if it is high, more than 2 standard deviation, that could also help in the diagnosis of sepsis. Now, all of us know that we are not using them. It's the clinical criteria alone. And procalcitonin is being used in de-escalation or stopping the antibiotic therapy only. Third thing was the hemodynamic variables, where the arterial hypertension, systolic less than 90 or MAP less than 70, or systolic decrease of more than 40 millimeter in adults or more than 2 standard deviation below the lower level of normal for that age. They included mixed venous oxygen saturation, more than 70%, elevated cardiac index, more than 3.5 liters per minute per square body surface area, square meter of body surface area. And then they had, third thing was organ dysfunction variable. That is, they're more like SOFA, a little bit more than SOFA. So in addition to hypoxemia, oliguria, rising creatinine, coagulation abnormality, where they included INR, paralytic ileus, absence of bowel sounds, thrombocytopenia, and hyperbilirubinemia, they were all included. Then they had tissue perfusion variables where hyperlactatemia, that is lactate more than 1, or decreased capillary refill or mottling was included. So severe sepsis was when there was organ dysfunction, and septic shock was when there is sepsis plus either hypotension refractory to IV fluids or hyperlactatemia. And, Mervyn Singer et al., they gave sepsis 3 definitions. The committee that was formed, they issued new definitions. They were more like, conceptual definitions. So sepsis was redefined as a life-threatening condition caused by dysregulated host response to infection, resulting in organ dysfunction. Whereas the septic shock was classified as or defined as circulatory, cellular, and metabolic abnormality found in septic patients, which presents as a fluid refractory hypotension needing vasopressor therapy and is associated with tissue hypoperfusion manifesting as lactate more than 2 millimole per liter. Severe sepsis term was eliminated. The term SIRS was also eliminated. And you would remember that they had coined the term QSOFA, altered mental status, tachypnea, and hypotension were the 3 criteria. And if any 2 were present, then the idea was that patients should be, the sepsis should be excluded in these patients. And this was to be used in ER as well as in the wards. And this was derived from a large database of more than 100,000 patients, identifying the most common factors which necessitated the rapid response alarm or trigger. However, now recently QSOFA has been abandoned. It has not been found to be very sensitive. So ladies and gentlemen, SIRS is back now. So the next part is evolution of sepsis management. Lot of things were there which have been modified. So let me show you the journey that, it was exciting time. My generation was fortunate because we saw the development from 1992 onwards. And 2002, the European Society, the American Society, and the International Sepsis Forum, they sat together and they declared, this meeting happened at Barcelona. It was called Barcelona Declaration. They said we will, work on sepsis, reduce mortality related to sepsis, and also streamline research and treatment modalities in sepsis. So 2004, the first adult guidelines were given. So if you see, the first guidelines were sponsored by an unrestricted grant by 2 companies, Eli Lilly and Edwards Life Sciences. So Edwards had a precept catheter which could be introduced into the superior vena cava like the IVC through the IJV. And It could be connected to a monitor, which would give continuous mixed venous oxygen saturation. And this was the time when we were also following the early goal-directed therapy given by Emmanuel Rivers, so that we identified restoration of MAP of 65 millimeter mercury by fluid resuscitation, etc., as achievement of macrocirculatory goals. And then to look at the microcirculation, we were doing the mixed venous oxygen saturation, either using the pre-sur catheter or intermittently doing the venous oxygen, venous blood gas, and looking at the venous oximetry. So if it was less, then we were suggested to initially increase the hemoglobin, bring it to 10, hematocrit to 30, measure again SCVO2, still low, then we were advised to start the patient on dobutamine as an ionotrope to increase the pumping action. This was called early goal-directed therapy. In addition, Eli Lilly had a drug which was the Zygris, which was the activated protein C that was infused IV to increase the activated protein C levels. However, like I told you, the drug was later withdrawn. So subsequently, the guidelines were modified in 2008, 2012, 2016, and the recent ones are 2021. And last two guidelines, 2016 and 2021, were really global guidelines because the ISCCM, our own society, was also involved. Dr. Yatin Mehta represented us, the Indian Society of Critical Care Medicine, and these were widely accepted. However, you should remember that there were a lot of concerns from Infectious Disease Society of America, which is a respected society, and earlier guidelines that we gave, which were also labeled as Surviving Sepsis Campaign, were not endorsed by them. However, the 2021 guidelines are endorsed by them because of the changes that have been made that I'll elaborate. So, what are these recent guidelines? You can see on the left-hand side is a guide to the recommendations. 2 exclamatory marks, green is a strong recommendation. 1 exclamatory mark is a very low recommendation. And if that is red, then it indicates against. Recommendation is against. And then you have high quality, moderate quality, low quality. So just keep in mind what is the type of evidence supporting these guidelines. So you will have this guide with every slide. So they suggested that we should be monitoring the improvement program in sepsis in high-risk patients, and there should be a sepsis screening, which we had a moderate recommendation. And this time they have recommended against using Quicksofa compared to SIRS, News or Muse, which are widely used by our ED friends as a screening tool for sepsis or septic shock. And although the recommendation is low, but they suggested that we should measure the blood lactate levels. And they suggested that treatment and resuscitation should begin immediately, which is quite logical. That is why it is labeled as a best practice statement. And for patients with sepsis-induced hypotension or septic shock, it was suggested that at least 30 ml per kg IV crystalloid fluid should be given within first 3 hours of resuscitation. So this was the suggestion, but the evidence is low. And this is slightly modified from the 2016 statement, where it was recommended. Now it is a suggestion. So it is eventually your call. So possibly do your dynamic fluid assessment and do your POCUS, and then take a call how much to fill up. For patients with sepsis or septic shock, they suggested that dynamic measures should be preferred over static measures like the CVP, etc. You can combine the two, but don't use static alone. And another suggestion was that the resuscitation, fluid resuscitation, should be aimed at reducing the serum lactate level in patients where they are elevated. That means it is mandatory to have serum lactate levels and targeting, bringing them down with resuscitation. And another thing that has made a comeback is what we Indians were already doing, capillary refill time. So that should guide us as an adjunct to measures of perfusion. So among the downstream markers, now capillary refill is given more weightage because lactate could be high because of other reasons also. And they also recommend that we should continuously re-evaluate our patients and search for any alternative diagnosis which may be mimicking the sepsis. And if that is the situation, then we should discontinue empiric antibiotics if we have an alternate diagnosis. And again, they suggested administering antimicrobials where we have possible septic shock or a high likelihood for sepsis. Now, this is the change. Possible septic shock or high likelihood for sepsis. There they are suggesting antimicrobials immediately within 1 hour of recognition. So, sorry, just a sec. And they are also suggesting that for patients who have sepsis, possible sepsis, but no septic shock, then rapid assessment for likelihood of infection versus non-infectious causes of acute illness should be made. So this is the course correction that the guidelines have done. So they are not saying you blindly give antibiotics, you do your judgment. Sepsis with septic shock, where the likelihood of infective sepsis, likelihood of sepsis and septic shock is high. There they are recommending within 1 hour. And otherwise they are saying look for alternative pathology. If you find an alternative pathology, non-septic pathology, you can stop antibiotics and look for non-infectious causes as well. And they are suggesting that wherever you are suspecting sepsis or sepsis, you have patients with sepsis but no septic shock, they suggest a time-limited course of rapid investigation. And if your concern for infection persists, then antibiotics can be given within 3 hours when you recognize it. So that is the distinction we have now. In these patients, earlier it was 1 hour only. So now if you have sepsis, they are making a distinction between septic shock within 1 hour, sepsis, but no shock, then you can wait for diagnostics and you can administer antibiotics within 3 hours. Again, they are suggesting that the criteria to diagnose sepsis should be clinical alone when you are starting antimicrobials, and you should not combine procalcitonin measurement with clinical evaluation. It should be clinical evaluation alone. If there is a high risk for MRSA, MRSA, then they recommend using MRSA cover also as part of the empiric antibiotic choice. And if there is a high risk in patients who are suspected to have sepsis or are in septic shock, high risk for multi-drug resistant organisms, there they are suggesting 2 antimicrobials for gram-negative coverage rather than 1 gram-negative agent. And this is another, important criteria which has possibly satisfied the IDSA, and they have given the risk factors also. We'll see the risk factors that they have given. Again, they are suggesting that if the risk for multi-drug resistance is low, then we should limit to 1 gram-negative agent rather than 2 gram-negative agents. And for patients, adults with sepsis or septic shock, they suggest that once the causative organism has been identified, then 2 gram-negative coverage should not be used. And again, they are suggesting that in patients of sepsis and septic shock, if the fungal infection risk is high, then empiric antifungal therapy can be added. Compared to earlier where they were saying that if you have a high suspicion of fungus, virus, you can add all these drugs. So that's the change. A more cautious, more practical and acceptable approach. For adults with sepsis or septic shock, where there is low risk of fungal infection, now they are clearly saying don't use antifungal therapy. So these are the risk factors that they have given for fungal infections. For Candida species, all of us know these: multi-site colonization, markers like BDG are positive, neutropenic patients, immunosuppressed patients, very sick patients, prolonged ICU stay patients, patients who have indwelling catheters and intravascular devices for a long time, drug abusers, patients on TPN, on broad spectrum antibiotics, gut perforation, anastomotic leaks, and where there is emergency GI or hepatobiliary surgery, or patients who are undergoing dialysis for acute renal failure, etc., etc. And for endemic yeast like Cryptococcus histoplasma, coccidiomycosis, they have said that the antigen marker should be positive. And if these patients have antigen marker positive, then they are likely susceptible. HIV patients, solid organ transplantation, high-dose corticosteroid therapy, hematopoietic stem cell transplantation, diabetes, etc. For invasive mold, which will include aspergillosis and the deadly mucor, neutropenia is a risk factor, and when serum or BAL galactomannan is positive, patients undergoing hematopoietic stem cell transplantation, solid organ transplantation, those on high-dose corticosteroid therapy, or on biological response modifiers. So this is a change that they have now asked the guideline users to identify these patients. There are no recommendations for antiviral agents. And another practice point, which in India most of us are following, is suggestion to use prolonged infusion of beta-lactams or maintenance over conventional bolus infusions. And I'll be jumping because I can't talk about all the guidelines. However, this paper is available so that you can see that. So they also suggest that we should assess, like we do sedation vacation, look for weaning, etc. Every day assess for that, SBT. So de-escalation of antimicrobials should also be assessed on a daily basis, rather than continuing on a fixed therapy and fixed duration with antimicrobials. And they are suggesting that where the initial diagnosis of sepsis and septic shock is there, but adequate source control is there, we can go for shorter duration of antimicrobial therapy. And wherever we have made a diagnosis of sepsis, septic shock, we have done adequate source control, but the optimal duration of therapy is unclear. Here they are suggesting use procalcitonin in addition to clinical evaluation to decide whether we can discontinue antimicrobials or not. So they are saying this decision should not be a clinical evaluation-based decision alone. You can use procalcitonin. So I think students will understand where procalcitonin is to be used. In terms of hemodynamic management, crystalloids as first-line agents, and they suggest using balanced solutions instead of normal saline, but the recommendations are low, as you can see, for balanced versus normal saline. And then they suggest using albumin in patients who received large volume of crystalloids, so moderate recommendation. And for adults with sepsis, septic shock, recommend against using starches for resuscitation. So you have one high negative recommendation not to use starches, and another moderate recommendation, negative recommendation, not to use gelatins also in these patients. And the first line vasopressor of choice, strong recommendation is norepinephrine. In case it is not available, then we can choose between dopamine and epinephrine. However, they strongly suggest that availability of norepinephrine should be increased. Second line drug is vasopressin, third line drug is epinephrine. And rather than escalating the doses of norepinephrine, they suggest adding vasopressin. And where despite these two, we are not able to maintain the adequate MAP, then there is a suggestion to add epinephrine. Now, these are some additional practice points that they have given. For example, Vasopressin can be started when dose of norepinephrine is in the range of 0.25 to 0.5 microgram per kg per minute. They suggest against using terlipressin. So this is a weak recommendation against. And also they suggest that if there is hypoperfusion despite adequate volume resuscitation and maintenance of adequate mean arterial pressure, then we can add dobutamine, or we can use norepinephrine alone, but low recommendation. And they suggest against, this is a negative recommendation, levosimendan in these patients where there is a cardiac dysfunction with persistent hypoperfusion, no levosimendan to be used. They are suggesting invasive arterial blood pressure monitoring in these patients of septic shock. And another suggestion, which has a very low recommendation, is that rather than waiting for a central line to be placed, we can start vasopressors through a peripheral line to restore MAP. So that's a change. We start fluid resuscitation and vasopressor simultaneously now, reducing the duration of hypotension as much as possible. Regarding restrictive versus liberal use of fluid, they said the evidence is not very, very clear. So they are not making any suggestion here. And for sepsis-induced hypoxic respiratory failure, they suggest they prefer the HFNO over non-invasive ventilation. And in terms of using non-invasive or invasive ventilation, they feel that the data is insufficient. So wherever data is insufficient, there's a question mark here. So same is regarding conservative oxygen targets. They say the data is insufficient as of now. Then the protective lung ventilation strategy is recommended. Limiting plateau pressure less than 30 or equal to 30 is recommended. And they suggest in moderate to severe ARDS to use higher PEEP compared to lower PEEP. And even in patients who are not in frank ARDS but have some respiratory failure, they suggest that we should continue using protective lung strategy with low tidal volume, and rather than using high tidal volume. And another thing which they have strongly suggested, that is recommendation 53, is we should not be using the escalation matrix for recruiting the lung because the ART trial was negative. And they said we suggest use traditional recruitment maneuvers. And traditional recruitment maneuvers are the CPAP of 30 centimeter for 30 seconds, 40 centimeter for 40 seconds, what we were doing 20 years back. And they recommend against using incremental PEEP titration or strategy. And there is a strong recommendation for using prone ventilation if there is moderate to severe ARDS, more than 12 hours daily. And there is a suggestion based on the recently published Rose Petal trial to prefer intermittent neuromuscular blocking agents, boluses, over continuous infusion, as was the practice based on the earlier Accurasis, the French trial. And for patients who have severe ARDS because of sepsis, they suggest using veno-venous ECMO when the conventional ventilation is failing. But they said it should be done in experienced centers with infrastructure in place. With septic shock, ongoing requirement for vasopressors, they suggest using corticosteroids in a dose of 200 milligrams per day. And in terms of the endotoxin and cytokine filters, they are clearly saying that we should not be using the endotoxin filter, that is polymyxin B hemoperfusion. This is after the negative UFAS trial was published, where they could not show mortality benefit with this therapy. However, they are not talking about any recommendation for cytokine filters because there is no evidence available as of now. So there is no recommendation here. They continue with the restrictive fluid strategy, restrictive transfusion trigger of 7 milligram per DL. Their recommendation is against using IV immunoglobulins. They have rated the quality of the studies where there was some benefit shown with IVIG as very low, poor quality. So not to be used, recommendation against. And stress ulcer prophylaxis in patients who have high risk for GI bleeding. Thromboprophylaxis should be used unless it is contraindicated, and unfractionated heparin is not preferred. The LMWH are preferred over unfractionated heparin, and combining this low molecular weight heparins with a mechanical device is not recommended because it is not superior as shown in a recent trial. And for AKI, we should go for renal replacement therapy. Then if the patient has sepsis and septic shock and there is no AKI, and there is AKI, but there is no definite indication for renal replacement therapy, they are suggesting against using prophylactic renal replacement therapy. And keeping the blood glucose less than 180 milligram per DL. They suggest against using vitamin C. They suggest against using soda bicarbonate therapy for hypoperfusion-induced lactic acidosis. However, they are suggesting that if septic shock is associated with severe metabolic acidosis, pH is less than 7.2, and there is acute kidney injury, Akin score 2 or 3, then we can use sodium bicarbonate therapy. We need to start them feeding early and enterally within 72 hours. And then some of the other criteria are routine palliative care consultation should not be done in all patients. It should be need-based on your clinical judgment. And lastly, I think I'll come to the last one. For patients who survive the sepsis and septic shock and who were in ICU for more than 3 days or who were ventilated for more than 2 days, they suggest referring to a post-hospital rehabilitation program, which unfortunately is very, very non-existent in our Indian ICUs. So these are some of the suggestions. And where are we? The last part is where are we in terms of the therapeutic interventions? I mean, if the mortality continues to be the same, although some of the basic care, the general care of these patients has improved, our understanding is better. So the researchers are looking at immunomodulation. We know immunosuppression would be corticosteroids, that is like the AK-47. This will cause, it's a broad spectrum immunosuppressive drug, and it will suppress both autoinflammatory and autoimmune responses, and this may reduce organ injury. However, this is too broad and it's controversial. So researchers are looking at identifying a particular area and then trying to use immunomodulators. So if a target where the which is an overactive pathway can be identified, which is leading to injury, that can be targeted, which can be seen here. So overcoming immunoparalysis is one area, and reverting hyperinflammation is another area of interest, where you have JAK-STAT inhibitors, IL-6R inhibitors, TNF blockers, IL-1R inhibitors, TLR inhibitors, and here GM-CSF and interferon gamma and other things. So they are trying to look at the specific inflammatory marker or immunoparalytic marker. However, this is a difficult situation because we have to have the means to identify these urgently, and then only we can initiate these therapies. So I think this is an area which will likely to develop in next decade or so. So to end my presentation. This was a nice paper by Finfer, which shows a general approach. So if we are suspecting sepsis, we should screen for sepsis using, now QSOFA is out, so we can use SIRS, SOFA, Muse, etc. Assess the organ functions. If a patient is hypotensive, shocked, or increased lactate, then we should start fluid therapy as well as vasopressor resuscitation immediately. Monitor hemodynamic and organ functions and obtain blood cultures, administer antibiotics, measure lactate, try to bring down the lactate. We can use IV crystalloids, and our macrocirculatory target is MAP of 65. We can, if it is refractory, shock persists, then we can add IV corticosteroids and other therapies for ventilation, renal replacement, nutrition, glucose control, venous thromboprophylaxis, blood transfusion, etc. And sedation should be minimized. Neuromuscular blockers are intermittent, early mobilization when stabilized. So thank you very much for your attention, and I hope this would have thrown some light on the journey through sepsis over last almost 3 decades now, 3 or 4 decades now. So I hope you enjoyed this lecture. Thank you very much for watching.